This is Endocrine Feedback Loop. I am your host, Chase Hendrickson, and welcome you to this Journal Club podcast series brought to you by the Endocrine Society. Thanks for joining us as we explore an important article recently published in one of the Society's clinical journals. Welcome again to the Endocrine Feedback Loop podcast for our 61st episode in the beginning of our 6th season. Today, we look at a clinical trial in the JCE&M that tries to understand the impact of genetics on the benefits of a lifestyle program in reducing the risk of developing type 2 diabetes. Personalized or precision medicine has been a hot topic for several years now, and this podcast has recently reviewed a few studies that fit that description. The authors of this investigation try to answer the question of how we can decide in advance which patients are particularly likely to benefit from a given intervention. Though this is a clinical trial and not an observational study, there are still several important methodological considerations we want to discuss. And as always, we will give you our thoughts on how the authors interpret their findings. I host the Endocrine Feedback Loop podcast and work at the Vanderbilt University Medical Center in Nashville, Tennessee, as a medical director and general endocrinologist. Returning today as the regular contributor for this episode is Ashok Balasubramanian from the Baylor College of Medicine in Houston, Texas. He serves as a vice president and senior associate dean there, as well as the director of their clinical scientist training program. He is well known for his translational research in diabetes, particularly atypical diabetes, as well as for being the immediate past chair of the Endocrinology Specialty Board for the ABIM. Joining us today in our virtual recording studio is our guest expert, Miriam Udler from the Massachusetts General Hospital in Boston, Massachusetts. She's one of the world's leading experts in genetic characterization of type 2 diabetes. Her research focuses on precision diagnostics and management in diabetes, and her clinical work centers on individuals with rare genetic forms of diabetes. So, as usual, the perfect pair of endocrinologists joins me to review this paper. As is also always the case, everything we say will be our opinions only and not those of the Endocrine Society or of our respective institutions. Today, we look at effects of genetic risk on incident type 2 diabetes and glycemia, the T2D Gene Lifestyle Intervention Trial, which was published in January 2025 in the Journal of Clinical Endocrinology and Metabolism. Maria Anneli Lankinen served as the first author for this paper and was joined by colleagues at the University of Eastern Finland. I will now turn the conversation over to Ashok. He will review the main points that the authors make in their introduction and have Miriam help us understand some key concepts about genetic risk in diabetes.
Hi, Chase. Thank you for this opportunity to discuss this interesting paper, which kind of takes off from the standard concept that underlies this complex disease type 2 diabetes, which is we know that genetic and environmental and lifestyle factors all contribute to the risk of developing type 2 diabetes. Now, the genetic effects, are generally considered to be fixed and immutable. So the question that should come up when we start to practice anything like precision medicine is these interventions that we use to make type 2 diabetes better, whether they're pharmacological or non-pharmacological, can they alter any effects of the genetics, of the genetic variants, right, that are conferring the risk of type 2 diabetes? So what are those risks and how do you quantify them? Well, it's well known that these large genome-wide association studies over many, many years have identified a large number of common variants across the genome that can increase the risk of type 2 diabetes. Now, individually, each of these variants exerts only a small effect. But is it possible that having multiple variants altogether in a single person may confer a sizable risk? To see what the sort of aggregated risk is, a number of scores called genetic risk scores or polygenic risk scores have been developed that take this combined risk due to multiple gene variants and try to establish a risk level for a number of complex diseases. And so we have these GRS, genetic risk score, or PRS, polygenic risk scores for type 1 and type 2 diabetes, which are well known. In general, it's thought that the predictive abilities of these scores are better for type 1 diabetes. And in this study that we're looking at, the Lankinen et al. Study, they're using a non-weighted GRS for type 2 diabetes that is calculated as the sum of 76 genetic variants known to increase the risk of type 2 diabetes. But I shouldn't ramble on because we have a real expert here on the subject, Dr. Miriam Udler. So I'm going to ask Miriam to please give us an overview of how GRSs work, right? What's the basis for them generally, and how do they apply to diabetes in particular?
Thanks so much for having me. Absolutely my pleasure to talk about this topic. So a genetic risk score, which as you mentioned, often we also call polygenic risk scores or polygenic scores, represents the aggregate effect on disease risk conferred by multiple single variants found in a given individual. So it's essentially a numerical estimate of a person's genetic predisposition to a particular disease. Now, the genetic variants that make up these scores have been discovered through large-scale genetic association studies. So these are very large studies involving thousands of individuals with and without a given disease. And the studies look across a whole genome to see which single variants are more frequently seen in people with or without disease. So importantly, the polygenic score, the genetic risk score, includes genetic variants that are in our DNA that we're born with and do not change throughout our lifetime. Now, the score that's presented in this manuscript includes 76 variants. Each of these variants is commonly seen in the general population, so all of us will have some of these, and they each have a really small individual effect on diabetes risk. So we think of this as odds ratios, and the odds ratios of each variant will be less than 1.2. However, even though each variant has this very tiny impact on disease risk, we can aggregate them together and have a combined score that improves predictability. Now, at the time that the study was designed in 2016, there really were at that time only 76 genetic variants that were clearly known to be associated with type 2 diabetes, which is why the score used these 76 variants. But now, incredibly, almost 10 years later, we have more than 600 type 2 diabetes variants, and methodology has also improved that we can have genetic risk scores that can include millions of variants, many of which will not reach statistical significance, but we have methods now that still can combine them together appropriately. So even though we have these older and newer scores, it turns out that even the best scores for type 2 diabetes still only have moderate ability to discriminate between people with and without diabetes. And just to contextualize this, so there's a test we use to quantify the predictive ability of a score. It's called the AUC-ROC, the area under the receiver operator characteristic curve. And it captures a score's overall ability to discriminate between people with and without disease. So people with and without type 2 diabetes in this case. A value of 1.0 would mean a test discriminates perfectly. And a value of 0.5 would indicate that the test is no better than flipping a coin or chance. Now, the AUCs for the type 2 diabetes genetic risk score only achieve a value of up to around 0.7. And for most complex diseases, this is actually quite typical. So polygenic scores in general for complex diseases usually only reach around 0.7, give or take. For a score to be clinically useful, the current thinking is that an AUC would have to be greater than 0.8 or 0.85. And in fact, there's only one polygenic score that's been able to reach that threshold, and that's the type 1 polygenic score that can achieve an AUC of closer to 0.9. So I think the takeaway here is that there's been a lot of genetic discovery for diabetes, and the genetic score for type 2 diabetes that is used in this paper has some discriminative ability and predictive ability, but it's fairly limited.
That was a really super overview, Miriam. Thanks very much. So let me go on a little bit more about the structure of the study and the strategy. Previously, in numerous populations, including the classic diabetes prevention program, as well as smaller studies like that in Finland and Japan, these have all shown that lifestyle interventions can lower the risk of developing type 2 diabetes in people with prediabetes. In other words, if you have a risk for diabetes, then lifestyle can help. And it's amazing that despite the diversity of these studies, you almost always come down to somewhere between a 50 to a 58% reduction in the risk. So it's a substantial reduction in risk by lifestyle intervention. Now, the question these investigators asked is, does the underlying genetic risk, if quantified by their type 2 diabetes genetic risk score, does that modify the good effects of lifestyle intervention in persons with prediabetes? To look at this question, they took advantage of a really excellent longitudinal cohort of pre-diabetic men in Finland. It's a study called the MET-SIM study, Metabolic Syndrome in Men study. And within that is nested the current study, which they call the T2D gene study. So the T2 gene study comprises people who are a subset of this cohort. And in these people, they tracked the 3-year incidence of type 2 diabetes. And there were 2 arms. There was an arm of MedSim participants who received a group-based lifestyle intervention, which shows quite similar to what was used in the DPP, a healthy weight-maintaining diet and physical activity. And this was compared with a control arm of also MedSim participants who did not get that intervention. Now, each arm was roughly evenly divided between individuals who had a low genetic risk score and individuals who had a high genetic risk score.
Yeah, we are now going to move into the methods, and Ashok's already done a good job of explaining from a high level how this study works. So what I'll do first of all is give you some of my thoughts about how this is structured. And the authors describe this as a clinical trial. I think that's accurate. This is a clinical trial. They are intentionally doing something. They are intervening in one group and not another. I would probably add a bunch of extra words to that description, and you can decide whether or not that makes it helpful. But I would describe this as a non-randomized, non-blinded clinical trial with a planned subgroup analysis. So we'll unpack those. So often when we hear about clinical trials, our mind will often jump immediately to RCTs, and specifically to RCTs that are blinded. So that's not what was done here. That randomization that is frequently done in clinical trials, the idea of that is you're trying to get rid of confounders, or at least to remove their effect. You want to make sure that there's not some other aspect of a population that you're studying that is driving an outcome of interest. And so to avoid that, you randomize folks so that way you should have the same number of confounders in one group versus another. And so they're going to cancel each other out, so to speak, so that there is not randomization here. The other thing that is often done in clinical trials is blinding. And the reason for that is you want to make sure that nobody is treating one group differently than another. You want to make sure that the intervention is not being applied differently, or that it's being assessed differently, or that the subjects are doing something different. And one of the ways that you do that is you just prevent anybody from in the groups of knowing whether or not they are in the intervention arm. Sometimes that's easy. If it's a pill, that's relatively easy to do. With these sort of studies, it's much more difficult to do. So this was not blinded here. And I would think of this, again, as this large study. They're looking at this lifestyle intervention, and then they plan a subgroup analysis. So they're going to look overall to say, hey, does this intervention lower the risk of developing diabetes? And then as a secondary question, is the effect different based on whether you have a high genetic score or a low genetic score? And we're going to think about that a little bit more. Again, this is how I would describe what the authors do. They simply describe it as a clinical trial. Okay, so back into this study, Ashok's described some of it already. So this was based on individuals who are in that MedSim cohort in Finland. So that's men ages 50 to 75. To get into that cohort, you had to have impaired fasting glucose, and maybe you had impaired glucose tolerance with that, but everybody had an A1C that was less than 6.5. So if you want to use the term maybe prediabetes very loosely, so not tying that specifically to A1C, that's essentially the population that's being looked at here. You did have to have a BMI that was 25 or higher. And Ashok mentioned this already, they intentionally chose folks who had both high and low genetic risk scores. They wanted a good representation of both of those. The authors point out here, I think this was interesting, that everybody was blinded as to what the genetic risk score was. One thing I think that we should be careful not to assume, that we see blinding as we'll often think, oh, well, this was a blinded study. It was not. So blinding, when we use it in that sense in a clinical trial, we are talking about an intervention being blinded, and that usually goes with a placebo control. So that's not what the authors are talking about here. They're talking about nobody knew which subgroup you were in. There may still be some benefit of doing that, so it's not a bad thing that you did that, but that's not what we're talking about when we say a study is blinded. So those are our subjects overall. Now we're going to describe both the intervention arm and then the control arm, because they were achieved differently. So the intervention arm was obtained by recruiting individuals from this cohort study, and they recruited 628 men, and again, wanted both high and low genetic risk score. So Miriam, another question for you. You did a great job already of describing these genetic risk scores. Help us understand, though, when you're dichotomizing into low and to high, how does that work? I would have assumed that maybe this is more of a continuous thing to be thinking about. That makes it difficult to split people into groups based on this. Help us understand how this dichotomization works and any factors that we need to be considering into those decisions.
So what the authors did here is they defined their high and their low. So the high was the people with the top 40% highest scores, and their low group was the lowest 40% of the population. And they based this on the larger MetSim cohort. So like you said, this is a continuous score, but they wanted some way of separating people with the highest versus the lowest risk. And you see this in various studies done differently. Sometimes people look at the top 10% versus the bottom 10%. It's a little bit arbitrary where you draw these cutoffs. And it's often the decision points in making those cutoffs have to do with the sample size that you have, your ability to recruit. And then also when you're thinking about your power analyses, what you think will be the effect size. So certainly, the higher you make the threshold, the stronger the genetic effect is for the high risk people, and the lower would be the lower risk for the lower people. So you can kind of dial that up or down based on these different factors.
One other comment on the intervention arm is that it was difficult for me. I couldn't figure out exactly how the authors decided who they were going to recruit to be in the intervention arm. I looked through this paper. They had also previously published a protocol that detailed this study and still couldn't figure out how or why these participants were chosen to be recruited. It does always make you nervous in general when the authors are being very selective about who they're recruiting to be in their intervention arm. It makes you wonder, well, why did you choose those people? Were they particularly likely to respond well or engage in your intervention? We don't know, so that may not be an issue, but I would say it was at least a question in my mind because I couldn't find that information anywhere. Okay, so that's the intervention arm. Now, the control arm, also men from this cohort, from this MetSim cohort. So they initially identified 589 participants, and they did that and they matched them to the individuals who were in the intervention arm. And then they invited these 589 men to participate. Now, only 345 of them agreed to participate. And though the subset was not very well matched for that reason, because not all the ones who initially had been chosen agreed to participate. And so that did reduce the power of the study a little bit. So we'll come back to that. Now, yeah, one thing I thought that was really interesting that I kind of liked, the participants in this control arm were unaware that they were in this study. They knew where they were in the larger cohort, but they didn't know that they were participating in this other study. So you don't see that very often, but I thought it was interesting and at least potentially limits the bias on the part of those participants. Okay, so we got two arms, the intervention arm, the control arm. Now the intervention itself. So this is a 3-year intervention program. Ashok mentioned it already, and it was based on group sessions. And these group sessions focused on teaching healthy diet and physical activity. And in that first year, there were 3 of these sessions for everyone in the intervention arm. And then for those men who had a BMI above 28 at baseline, there were 2 additional sessions for them. The sessions included food records, and then the participants got written feedback from nutritionists on their food records. There was a minimum goal of at least weight maintenance in this intervention. And as far as the assessment of the intervention, there were labs that were measured for the intervention group at years 1, 2, and 3. Interestingly, for the control group, the measurement was only at year 3. The authors point this out in their discussion, but it is a little bit atypical to be looking for outcomes differently in different groups. It does make you worry that you've missed them whenever you're looking less frequently, and the authors mention that. Okay, so that's the intervention. Going into detail about the outcome. So their primary outcome was incident diabetes. So they were looking for the development of diabetes, and that was based on either fasting glucose, on oral glucose tolerance test, or a hemoglobin A1C. And then additionally, if there was evidence that an individual had started a diabetes medication, that was also taken as proof that the individual had developed diabetes. There were multiple secondary outcomes, and we're going to talk about those shortly, so I'll hold off on those for now. Finally, just a few comments on the statistical analysis. So one thing that I like that the authors did, so they were trying to decide how many individuals they needed to have. Mary mentioned power calculations already, so they had to decide how many people do we need to get in here to have adequate power. All of the intervention studies before, at least the ones they looked at, were individual one-on-one interventions, and the authors are saying, well, we're doing group interventions interventions here, so we're not quite sure how effective that's going to be. So we're going to look at how many individuals we would estimate you need based on a one-on-one intervention, and we're going to double that because we don't know that a group intervention is going to be as effective, so we're going to have extra subjects in here just in case. So I like that approach. One other thing that they did, so going back to this issue with the control and the intervention arms not being particularly well matched. Again, they were initially when they invited people, but a lot of the control arm men did not agree. And so at the end of the day, they weren't very well matched. The investigators did an assessment for multiple comparisons. So this is frequently done in studies whenever you're looking for a lot of different outcomes and you're worried that, well, if we're looking at so many of these, what if we just find one or two or three that are significant purely on the basis of chance? And so you'll do these multiple comparisons, and the specific one the authors did here was what's called a false discovery rate. And let's try to minimize that chance. I thought this was interesting because I'm not sure that I've ever seen this done before in this way, which is to try to minimize concern that your two groups are different from one another. Again, it's usually looked at with results, trying to make sure that you truly found a difference. The authors used is to say, well, initially, some of these p-values suggest that these groups are different from one another, but we think that they're not actually that different. So I'm not sure about that. I've not seen that before, so that was maybe a bit of a surprise to see that. And I think something that'll be worth keeping in mind is this question of, well, you recruited individuals to be in one group. It's unclear how they were recruited, and then the data would suggest that maybe these two groups aren't exactly equal. So we'll need to consider that as we move forward. Okay, enough of the methodology. Ashok, going to turn it back over to you to walk us through some of the results of the authors report here.
As Chase mentioned, the study began with 628 men. Their mean age was in the mid-60s. Their mean BMI was in the overweight, but interesting, not actually in the obese range, amongst those who were recruited to the intervention arm. And 311 of these had a low GRS, and 303 had a high genetic risk score. And on the control side, as Chase mentioned, there were fewer participants, 589 men, and 196 of those had a low GRS, and 149 had a high GRS. The primary outcome measure was the incidence of diabetes in these people. Remember, they all started off with pre-diabetes. So what is the incidence of diabetes after 3 years of follow-up? This is where the results are interesting. In the intervention arm, the conversion to type 2 diabetes was 7.7% in the low GRS group and 8.2% in the high GRS group. Now, this contrasted with the control arm, where the conversion rates were 8.2% in the low GRS group and 14% in the high GRS group. So if you just look at the control arm for a second, it starts to look as though there is some congruence between having a high genetic risk and the higher rate of actually developing diabetes over 3 years. And, it looks like it might have been attenuated in both of those groups by the intervention. Now, how was that quantified? Overall, the intervention, that is taking everybody all together, overall, the intervention lowered the type 2 diabetes risk by 52%, which again is so close to the results of things like the DPP, etc. But importantly, for the purpose of this study, those in the intervention arm with a high GRS, right? These are the people with a higher risk, actually had a significant 70% reduction in risk. Those who started off and had a low GRS did not experience a significant difference compared to the control group with low GRS. So think about that for a second. The high-risk guys, the intervention seems to have a big difference. And in the low-risk guys, the intervention does not seem to have a statistically significant difference compared to controls. However, there were definitely benefits with the intervention for those with a low GRS in other sort of parameters of glycemic control. So the increase in fasting glucose that happened in the controls was attenuated, and the same with a more quantitative measure, which is the area under the curve for glucose after a glucose tolerance test, as well as an improvement in insulin sensitivity as measured by something called the Matsuda index. I'd actually like to ask Miriam at this point, what do you think of these differences, between intervention, non-intervention, low, high risk? What do you think that means?
Well, I think, the results are really interesting. Two important points that come to mind are that when we look at the low genetic risk versus the high genetic risk, as you mentioned, they both had some response to the intervention in that assessment of their responses in comparison to controls. And I think, it is a little bit challenging what Chase had mentioned earlier, that the control group, we're not really sure how well matched they are to the intervention group. And so in particular, when you look at that control group that has a conversion, so the high risk genetic control group has a 14% incidence of diabetes, which is actually higher than would have been predicted from the overall MetSim study that they'd published earlier, and suggests to me that maybe those are people that had a higher genetic risk than the intervention group, because that 14% is pretty high. So certainly, we see this reduction in both groups that's only significant, though, in that high risk group. And I think it is important to note that both the low genetic risk and the high genetic risk with the intervention had very similar incidence of diabetes. So in other words, if you didn't look at the control group and just looked at the intervention group, they're very similar to each other. And our sense of how they differ from each other is really contingent on this comparison to the control group that may or may not have some challenges to it. Another thing just to think about that's kind of interesting is there's this idea that when you select for people that have impaired glucose tolerance or, features of pre-diabetes and haven't yet developed diabetes, which is the case in the study, right? And then you say, look at those people that have a high genetic risk within that group. There's a little bit of a bias that can happen, because in order for somebody to not yet have progressed to diabetes and have a high genetic risk, and what we see here is that the high genetic risk group actually had like a higher baseline Matsuda index. So they actually were more sensitive than the control group. And so we see that the intervention led to stabilization instead of worsening of, for example, with the Matsuda index. But I think what's really interesting is that I think also why we see the effect of the intervention more in the low genetic risk group is that they start off more insulin resistant. So those are just things to keep in mind. So when we look at differences between the two groups, there are some baseline differences also, and that some of those are probably related to this a little bit of a bias of why someone with a higher genetic score hasn't yet developed diabetes that has these diabetes risk factors.
We'll come back to discussing some of these results. It's a very intriguing set of results, but there are some confounders. But just to close off some of the results, the other interesting outcome was that irrespective of the genetic risk, the intervention induced more weight loss in the intervention group than in the control group. So it was effective across the board. Interestingly, also, there was some sort of behavioral sorts of improvements. The dietary nutrient intake of those getting the lifestyle, instruction, as well as the exercise, were doing better in terms of a healthier diet and were chronically improved in terms of their physical activity. So a lot of things to think about. So I'll turn it back to you, Chase.
We'll move into the discussion. We'll start with a couple of quotes from the authors about related findings. So first of all, the authors say, lifestyle interventions significantly prevented the conversion to type 2 diabetes in the participants with a high genetic risk. And then no significant difference between the intervention and control arms was observed in the participants with a low genetic risk. The authors then move on to elaborate on this finding that there was no difference in the intervention effect comparing the high and the low risk groups. And then from that, interestingly, the authors concluded that this data suggested that both groups benefited. We'll discuss this as a group. I'll start by giving my thoughts. And I would interpret this a little bit differently. And a part of this is because I have chosen to view what they did through a certain lens. And so the authors may say, well, that's not how we're viewing this. But I think if you look at this as an overall intervention study, looking at the effect of a group lifestyle intervention, and then you say, and then we plan to do a subgroup analysis. The typical way to interpret that would be to say this lifestyle group-based intervention was effective at lowering the risk of progressing to diabetes. And we looked to see if we could tell if the effect differed based on this subgroup analysis, based on your genetic risk score, and we couldn't clearly show that the effect was different in one group versus another. So that's how I would do it. Again, the authors looked and said, there's an overlap in the effectiveness in both groups. So we would interpret that as saying that it's effective for both groups. And I would just say you can actually tell a difference there. So maybe a bit too in the weeds there to be helpful, but potentially from a powering issue, the authors talk throughout the paper about trying to get the powering right. And this is difficult, particularly with subgroup analyses. And I do at least wonder if, well, maybe there is actually a difference between the high and the low risk groups and just there weren't enough individuals in there. And so that's why you couldn't see. The point estimates, as Ashok has mentioned, suggest that there could be, but there were overlap in those confidence intervals. Miriam, though, why don't we get your thoughts as far as how the authors interpret their findings? Do you agree with them, disagree? What are your thoughts on that?
I think I can see both perspectives. To me, the most important takeaway that we've been kind of touching on is this idea that genetics isn't everything, and especially when it's kind of a weak genetic estimate of risk. So I think this is like a very reassuring, wonderful result that even if you're somebody who has high genetic risk, lifestyle interventions are very effective. Whether they're more effective or just as effective in a low-risk group, the interaction is not significant. There's a suggestion that maybe it's more effective, but honestly, like the magnitude of difference, I'm not sure even really is that clinically important, because just knowing that really for any patient, if you do lifestyle intervention, is going to be effective, I think is really the takeaway message, that you shouldn't be discouraged. Although I just will note that part of why you shouldn't be discouraged with a higher genetic score is that score is not the most predictive score anyway to begin with. But yeah, so I think it's a really important finding. I think one challenge or limitation is that in a perfect world, you might want your initial randomization to be where you have people that you first took based on their polygenic score and then randomize them, just to ensure, as we were talking about, we're not certain that the control group is really randomized or similar to the intervention group. There may be some differences there that could have affected the results. But yeah, there's some limitations maybe in the interpretation, but overall, this message that's really loud and clear and reverberates in other studies as well, that lifestyle can be effective regardless of a polygenic score value.
It's interesting to listen to you both, debate these two perspectives. Sitting back and listening to that, it seems to me that Chase, in one sense, is absolutely correct. The overall effect of the intervention was this, but the subgroup analysis showed no difference really between the groups. And should that be the overriding conclusion? And Miriam, you've also brought up the point that while that is true, there is something satisfying about knowing that lifestyle works for everybody. I think that from a clinician standpoint, the positive aspect of the take-home is this does not vitiate or negate any of the great lessons we've learned from the DPP. You should really push the exercise because it comes out to be 50% effective in prevention, regardless of what happens, and please do that. I wonder, on the other hand, if it also undermines our interest in promoting genetic diagnoses in complex diseases, right? Because the other way a clinician can look at this is say, I'm glad I don't have to spend any money doing genetic risk scores because they're kind of useless anyway, and the intervention works. So, I think there's food for thought from many perspectives. I would kind of go with the first two. Yes, it gives you different conclusions, but it should be useful in clinical practice to know that lifestyle works. It also points out that we need to improve our genetic risk scores so that the difference you see is actually something meaningful in regard to how much lifestyle it takes to overcome it or not.
At the end, we will come back and think a little bit more about whether this should change our practice now or if, in fact, we do need to wait until our genetic tests are a little bit better. Well, the authors move on and they talk about a few specific glycemic indices that were improved in both groups, as Ashok mentioned, both the high and the low risk groups. And so, Mary, maybe we'll start with you. You've given us some thoughts on these already, but just give us an overall, a lot of these indices improved. Any of those jumped out in particular, say that one seems like a really clinically meaningful improvement in this indice for somebody who's at risk for developing diabetes?
Everything we're seeing for all the improvement probably correlates with weight loss, would be my guess, because we see the intervention group compared to the control group, had weight loss. So I actually feel like it's interesting to see this, but I think the differences are very small between the high and the low risk group. I'm not sure that they're that clinically meaningful. So the biggest effects that we see are just the intervention in maybe staving off weight gain or causing weight loss. And that's really the major things that I see in terms of the different glycemic measures.
Ashok, any other thoughts in addition to that?
No, again, I think clinicians will be drawn to, their figure 2B, which clearly shows a difference in terms of one of the gold standards for diagnosing diabetes, which is a 2-hour glucose. There's a big difference out there. All the rest of it seems like small differences and calculated.
Another question for Miriam, because the authors go on and they talk about some of the other data that's out there in the medical literature, and they point out that their results are comparable to a couple of previously published type 2 diabetes prevention trials that showed the effectiveness for participants with a specific variant. So this was the TCF7L2 variant. All right, Miriam, you're going to have to help us out here and unpack what that means. Well, what is that variant, and how do we need to be thinking about that in particular?
Okay, so this variant TCF7L2 is the most significantly associated variant with type 2 diabetes. So it has like the most significant effect and the largest effect. Even still, though, this is like the one variant that reaches an odds ratio of 1.2. 1.2 is like tiny. This is the effect that it has on diabetes risk. There was a paper published in the Diabetes Prevention Program and also other intervention studies back in 2006, 2007. That long ago, we were looking at one variant at a time. Nowadays, I don't think anyone would ever look at any of these diabetes variants on their own because they're just really have very little utility in terms of discriminating risk. That being said, in the Diabetes Prevention Program, there was also an analysis looking at a polygenic score, I believe 34 variants. So this is also an older study and had almost the exact same results from this present study, showing that the lifestyle intervention had a benefit. They looked in quartiles of the highest quartile and the lowest quartile, but then also no significant interaction. So I think all prior work is consistent, but I would say that TCF7L2, I don't think there's real clinical utility in looking at a single variant.
Authors also point out in the medical literature that there's quite a bit of heterogeneity in terms of how diabetes is defined in these studies. And so they acknowledge that those different definitions highlight different underlying pathophysiologies. And so we shouldn't necessarily just lump them all together and assume that they are telling us the same thing. And the authors, finally, they conclude that, and this study really does show the effectiveness of a group-based approach. And that was a question that they had because a lot of the previous studies they were comparing themselves to were individual-based approaches. Okay, so the authors list a few limitations, and so they point out that only men are included in this study. They also mention that they were not able to include as many participants in the control group as desired, though they do point out that it is adequately powered. And I'll add as a comment, though, that I think that poor matching issue does remain as a separate concern. They say that there was no randomized control arm, which I interpret that to mean that the intervention was not randomly assigned to some folks and control randomly to others. And they also mention that diabetes in that control arm may have been underestimated given the fewer points of measurement. The authors conclude their work, and I'll quote them here again. They say, first of all, type 2 diabetes can be prevented or delayed by a low-cost, group-based approach focusing on healthy diet and physical activity. And then they go on to say, since lifestyle intervention was equally effective in lowering glycemia and weight compared to population control groups, all individuals at risk for type 2 diabetes should be encouraged to make lifestyle changes regardless of genetic risk. Okay, so we're going to get back to that. Should this change our practice here? Or do we need more information? So we'll sit tight on that for just a second. But just thinking about the quality of this report overall, Ashok, let's start with you. You spent a lot of time working through this study. What is your sense quality of this study as a whole?
Concluding sentences that you quoted are almost verbatim the conclusions of the DPP, right? So you can ask yourself, what has this study done to advance our thinking about lifestyle interventions over the past 15 to 20 years? The only point it's making is, again, the one that could be taken negatively, which is not much use for the current state of genetic risk scores in terms of how we practice medicine. But I hope that's not what people walk away with. I hope they walk away with thinking, yes, the positive aspect is everyone benefits, but also we're on the threshold of doing genetically based precision medicine. And I can't wait for the day when we actually get precise scores that will gauge risk better and also guide people to other treatments off the bat. I mean, suppose somebody with a high, a really perfect GRS, was unsurmountable by our lifestyle. Well, we shouldn't just tell everybody to do lifestyle. We would pick those people early and guide them into some new therapy. I just don't want people to take kind of the Luddite view over here,
Miriam, your thoughts on the quality of this report overall?
I agree. I think it's also important to remember that this study was designed in 2016 or earlier, right? That's when that design study, I think, was published. So the field has moved so quickly. And we mentioned the diabetes prevention program findings, everything, as we view it now, we have 2020 hindsight. So I think the study at the time was really innovative, and the fact that they were trying to do a randomized approach for intervention in randomizing or separating people based on genetics. I think that's like fantastic that they were doing that. 40% as like a high risk group, 40th percentile, top 40th percentile. That's a very large group. I think that's a show convention that as we get better scores, and also probably we need to be making the threshold that we would want to consider like highest risk going to be even higher genetic risk. Then, there'll be fewer people, so it'll be harder to recruit those people, but those are the people who are going to have the most need and the highest risk for developing diabetes.
All right, Miriam, we'll stay with you to close things out. And I think we've gotten a pretty clear sense as far as changing practice that this specific study may not move us, at least in terms of doing genetic testing, and the authors themselves don't suggest that. But give us an overview. So you spend all your time here. You're the expert here. Do you see this as something as with more recent modern approaches? Does this have the possibility of changing our practice, or are we on the verge of potentially doing this? Or no, we need to refine our techniques before we're ready to start doing this clinically as a standard approach for our patients with diabetes?
I think there are places where genetics is really powerful right now in current practice. So we have I wouldn't say rare, but less common forms of diabetes, monogenic diabetes. Still 1 in 250 cases where we do genetic testing, and that has, a very big effect on getting a genetic diagnosis that helps us understand the patient's diabetes and often leads to management decisions. So genetics, and it's certainly useful in general. At this point, with polygenic scores, I don't think the type 2 diabetes polygenic score has a clear utility at this moment in time, but I definitely think that can change. And as we get better scores, and as we need to identify kind of where that threshold is, where people have a high enough risk that it's meaningful to do something. And, the type 1 polygenic scores we mentioned, that actually, is fairly predictive as an AUC of 0.9, and it's starting to be used in clinical practice. So overall, I think there's a lot of room for precision medicine, for genetics to be improving our care of patients. I'm very much in favor of that. I just wouldn't want to oversell places where I don't think it is as useful. And so right now, the type 2 diabetes score I don't think is as useful.
And with that, I would like to thank Ashok Balasubramanian and Miriam Udler for joining me for this month's edition of Endocrine Feedback Loop. I hope that you all learned as much as I did, and that you will join us again next month. And now you're in the loop. This has been Endocrine Feedback Loop. Endocrine Feedback Loop is brought to you by the Endocrine Society with production oversight by Brandy Brown and Andrew Harmon. If you want to like and subscribe, you can find us on Apple, Spotify, or wherever you get your podcasts. We'd love to hear your feedback on this episode or the podcast itself. Please email us at podcast@endocrine.org.
Endocrine Feedback Loop is a free service of the Endocrine Society. To learn more or to become a member, visit the Society's website at www.endocrine.org.